Hello, my name is Tyrell Steins, Critical Care Coordinator for Lifestar Emergency Medical Services, and this month we're going to be talking about NPPV, CPAP, and PSV. For Lifestar for 2020, we had 79 calls last year, and we had 21 so far this year. And it is at the beginning of April. So they happen quite a bit. At the start of this shift, every morning that you get on, you're going to do your normal rig check, look at everything, and then you're going to do your normal critical care responsibilities. So the ventilator should be preset with the circuit all set up, the filter on, the end tidal on, and everything ready to go, because in our protocols, you are allowed to use the ventilator pre-hospitally, both for non-invasive and invasive. So it should already be pre-set up, and then you are going to run it through its test, make sure that there are no circuit leaks. Everything should be taped and secured. You slide it back in the bag that it came in. The battery does need to be charged. There is both an internal and an external battery. The external battery we can see it on the ventilator itself on the NV screen. We can also press the button on the side of the external battery, and that'll show us how many bars it has and how charged it is. So every day, regardless of who is on, you do need to have it charging for an hour or two. That way the internal battery that we can't see is still getting charged properly. Also, equipment check. You should be going through the gray CC bag. You should be looking at everything, making sure everything is there. You know, one of the benefits of us getting the ALS Tempest monitor is that our bulky old ProPack Artline monitor will be going away. And so that will provide more additional space in the ambulances. The stations that the ambulances have the ventilator on them and all of the CC equipment on them. Those rigs will be gaining more space because we'll no longer have that bulky ProPack, but rather we'll have the ALS Tempest monitors. And then the critical care rigs will have the dongles added to the gray CC bags. So there's no excuse to not have it set up, as it is something that we can have with pre-hospital. All right, I turn the ventilator on, and then we can go to vent setup, and then EST, and then I've already weighted the time amount, so we can then test our circuit. Wait and follow the directions, include the Y. So our circuit passed, so then we can hook it into the test lung. So that is all hooked up. With different calls, you do have simple non-invasive calls, and you can get very, very complex invasive calls. I've had both super stable ones where it was really questionable whether they needed to be on non-invasive. And then I have also had very complex ones where you literally, just the manner of switching over the mask causes them to decompensate significantly and desat significantly. And so there are the easy ones we take, and then the harder ones that we take. Just like with everything, some of the invasive ventilated calls, intubated ventilated calls we have are simple and easy. And some you are fighting tooth and nail the entire way down to the next hospital, trying to stabilize the patient and make things better. Setup, we'll look at a video here shortly, but the preferred method of how to set up the ventilator for a non-invasive call is turn it on. It's going to cycle, run through, turn it on, hit the non-invasive, hit start. It's going to automatically give 4 to 5 breaths because it's trying to detect the patient. It's going to be angry. It's going to be beeping. Silence it right away. Then put in your settings, and it will quit attempting after the 4th or 5th breath because it can't sense a patient. It can't sense any pressure resistance. And so it thinks it's just detached. So it'll try 4 or 5 times, then it will just stop attempting breaths altogether. So hit the silence button, type in your settings, then click on standby. That way your settings match the hospital's and they're ready for you when you hit start resume. it'll start pushing out air and you can push the mask onto your patient. The NV does default at 21/6 for the NPPV pressure mode, and it does default at 16/6 for NPPV CPAP PSV. The biggest thing that we don't want is to click non-invasive and ventilate, and it'll automatically start 16/6. And if your patient is, say, 8/4 or 10/5, they're going to get quite a bit of boost until you get those settings dialed in. And so that is what we want to avoid. So the preferred method is to start it, silence it, put in your settings, then put it in standby mode, wait a couple seconds, and then hit resume to then put the mask on the patient. One of the problems with the ventilator pausing after those 4 to 5 breaths is that if you put the mask on at the wrong time, you didn't put it in standby mode, you just let it stop itself, so now it's just paused. It'll say circuit failure because it thinks that there is a circuit failure when there's not. One of the problems is that those first couple attempts at a breath do not go well. It does not immediately recognize that you've now put it back on the patient, and so sometimes it needs a little teeny breath in order for it to actually recognize, and sometimes a bigger breath will cause it to trigger. I've not figured out the exact science as to when you let it be off the patient to the point that it stops attempting to ventilate, what are the key parameters to get it to start again. That's why if you start it, silence it, put in your settings, then put it in standby mode, then when you're ready to put it on the patient, that way it'll start up instantaneous without a problem. All right, the other method of doing this is everything is all hooked up already. We have our elbow, we have our end-tidal CO2, we have our filter, everything is there, and we turn on the vent. We would have already tested it for today, first thing that we do at the start of a shift. And so select non-invasive. It's going to scream, and we're going to set up everything here. And I'm going to do 8/4, so you can see the 4/4. It's screaming, it's unhappy. You can hear it go, and it's trying to find somebody breathing. It's obviously not finding anybody breathing, and eventually it will stop. And so it'll say patient circuit failure because it didn't find anybody to breathe with.
So they died.
This is recording. So it didn't find anybody to breathe for, and that you could just leave it like that. The easiest thing would be to put it in standby mode. We have our settings set. Now we can unclip, pull up and over. Then we unhook the hospital one and then click resume, and it will breathe. Take a breath. We can hold the mask. And so right now the patient is on oxygen. Everything is going, and I'm back, and my ventilator is happy again. So flip over. So again, your partner is where can help you a lot with this, or your patient. Since my patient is relatively healthy, do you want to grab the mask and hold it right here? So they can hold it themselves while you get everything adjusted. And so it's obviously challenging to be careful and mindful of the hair. Click into place. So, does that feel relatively comfortable? You look thrilled. So, need be the best way to adjust the top or the bottom is to pull out together bilaterally and then place it. The other method that you can do is put it on a test lung. So you'll click non-invasive mode, you'll hit ventilate, you'll have it on the test lung. The apneic period default is automatically defaulted to 20 seconds. And so as long as you poke the test lung less than every 20 seconds, it will think that the patient is breathing, and then that'll keep it happy that way. So that is an option for switching over. So that way you can get your settings dialed in before you put it onto the patient. So we have NPPV CPAP PSV versus MPPV pressure. There are two different types of modes, two different types of non-invasive modes in the NV ventilator, and we'll go walk through those. All right, we're going to look at PSV, pressure support ventilation, versus NPPV pressure, non-invasive positive pressure ventilation. Both are available modes of non-invasive in the NV ventilator, and we're going to set it to, let's do 15. We'll do 15 over 5 for both of these. And so in the PSV, what we are going to have is we have a PEEP, which we are going to set to 5. And over in the NPPV pressure, we also have a PEEP, which we set to 5. So this is going to give us a baseline of 5, and it's time on the x-axis, and then it is pressure on the y-axis. So in PSV, we have a PEEP, and we also have the PSV, which let's set to 10, because that makes, it's always additive flow with the NV ventilator, and so that's going to give us our 10 over 5. The difference with the NPPV mode is that you are going to get a inspiratory pressure, which we are going to set to 10 because it's additive, so 15 over 5. And it will also give us a respiratory rate minimum. So let's just say this is set to 12. And so looking at these two, in PSV mode with the patient on the mask, when they take a breath in, they will breathe in, you're going to have your minimum PEEP. And so they're going to go up to 15 and back down in some time increment. If they want to, they can take a little short breath, and it's going to attempt to get up to that 15. 15 is what is flowing into them. That's the pressure. So whenever they allow that pressure to enter their lungs, it's coming in at 15. It's not necessarily going to reach all the way up, but they can do it for whatever time frame they want. If they want a little teeny short breath, time-wise, they can. If they want a long, drawn-out breath, they can. And so the patient is very much in control of their own breathing. Now, in NPPV mode, we have a minimum rate. So as long as they're breathing faster than the rate of 12, then they get to choose their own respiratory rate. And so this is a conscious person, and they get to set the rate to whatever they want. Our inspiratory pressure is 10, our PEEP is 5, so we have that minimum. And then it's going to be additive, so it'll be 15. So whenever they breathe in, they are going to get 15. And so they take a breath in, it'll be 15, and it'll be given. The key difference is if they, let's say they only want a short little breath, and so they're going to try for a short little breath. However, the NPPV demands that there be 15 reached, and so that's going to add and give them the full 15. This is very, very similar. In fact, there is no difference between the invasive mode pressure AC and NPPV pressure. You know, NPPV pressure is basically BVM mode, and if your patient's not breathing fast enough on a non-invasive mode, what would you do in the field? You know, let's say you put them on CPAP in the field and they're not breathing fast enough. They're breathing too slow, they're too fatigued. What would you do? You would grab the BVM and then use the BVM with PEEP to provide that minimum respiratory rate that you desire them to have. And so NPPV pressure lets you dial in a rate. It also lets you dial in an I time. So you actually will end up having an I time, which will always default to 1. The default settings for the ventilator for PSV, it is 10 over 15. I'm sorry. For default for PSV is set to 10, PEEP is set to 6 by default. So default, you're automatically going to go 16 over 6. Whereas in NPPV mode or in pressure AC mode in invasive, you're always going to default to an inspiratory pressure of 15, a PEEP of 6, a respiratory rate of 12, and an inspiratory time of 1. So you're always going to default to 21/6, whereas in NPPV, CPAP, PSV mode, you're going to default to 16/6. The biggest pros and cons to both of these, PSV really, it allows you to do your own thing. And so the patient is the one that gets to choose what they want to do. Short breath, long drawn out breath, yawn, etc. They're in control, and it immediately stops. It doesn't have to reach a certain pressure before it times out. And so it is take what you want. It's a la carte, basically. PSV mode, or NPPV / CPAP PSV mode, is easier for the patient. Or rather, it is easier for the patient who are not fatigued. And so you're awake, you're conscious, you can take and deal with whatever you want to deal with, and it's 100% up to you. One of the advantages of this mode is it's less precise. You have to be less dialed in because, once again, the patient is the one who is controlling everything, and it's whatever they want. One of the pros to PPV pressure, aka BVM mode, aka pressure AC, is that you get the full pressure. You get the full amount, and it's not up to the patient. And so if the patient is getting really fatigued and just wants to tick it, they can just do a little teeny breath in, suck in a little bit, and it's automatically going to kick in and give that full amount. And so it's better for the fatigued patient who is just tired and pooping out, and we are trying to bring them back and pull them back from getting tubed. They're not going to get intubated yet, but we all know that it's really beneficial to the patient to not have them tubed. If we can save them with a non-invasive mode and bring them back, it's better than tubing them. How many times do we tube? How many times does that patient ever get to leave? It'd be interesting to find the statistics out there of the number of 80-year-olds that are intubated, how many ever come off the ventilator. What are your chances at 80 or 85 or 90? If I tube a 93-year-old or a 90-plus-year-old, I'm expecting that they're never going to get off the ventilator. Like that is a very hard road, and we intubate you, we RSI, we intubate, and what happens next? What's the other side? In paramedic school, we spend so much time learning how to intubate patients and learning how to properly RSI or DFAM or DSI or whatever acronym you like using. We spend so much time learning how to, and then in critical care, we spend a lot of time going, let's fight tooth and nail to not intubate, so that way we can avoid intubating, we can avoid having to go down this slow path that so oftentimes leads to permanently on the ventilator. And we tube you, you're just not able to recover. You're not able to get off of the ventilator. They put a trach in you, and so now you're on a trach ventilator. The likelihood of infection and then sepsis and that reoccurring cycle of septic shock and the weakness, trying to build back up your strength, trying to get off of it again. And so it's best if we can avoid that altogether. Obviously, you have to do what's in the best interest of the patient, and sometimes that is intubation. But have we adequately fought tooth and nail and giving you the best chance that we can to not intubate you and not have you go down that path? And so PPV pressure is a great mode, and aka BVM mode, or this is non-invasive pressure AC. It's better for the fatigued patient who's really tired, who all they want to do is just trigger, and it'll automatically give that full amount. It's nice because it gives us a minimum rate, And so if we need that respiratory rate to go up, that is nice. The other thing too is if you are fatigued, it also gives us a inspiratory time. And so that is a nice thing to have to be able to control, so it's a much more precise mode. And if your patient is really fatigued and just wants more rest, it's going to be a better option, but you have to dial it in way more precise. With PSV, it's way less precise. The patient can take, have their own I time be 1 second. They can have their own I time be half a second. They can have their own I time be 2 seconds. It's on your own, but you have to have enough energy and be with it enough to have your own body choose that, not be pooping out and croaking. You can't be fatigued to the point of going altered, and so it's PSV is a lot less precise, a lot easier for a patient, but they need to be more with it than NPPV pressure. Look at our screens and look at the controls is what we're looking at, and look at the difference between when you first start up in non-invasive, you start up in NPPV CPAP PSV mode. If you switch it to NPPV pressure, aka BVM mode, if you look at NPPV pressure versus pressure AC, you can see that there is no difference. That's why it's like a BVM mode. That's why they're the same things with the same settings. Looking at the face masks, just a reminder to everybody, the old school masks that we had large, medium, and small sizes. Now with the new masks, we have the old large is now the new medium. The old medium is actually a small, and then the small is an extra small. So the sizes that we now carry are just called different: extra small, small, and medium. Obviously, you can use the Bi-PAP mask. If you really can't get a good seal and there's nothing you can do and you've tried everything, I would actually switch to our CPAP masks, the FlowSafe 2 masks. You could actually use that. Those are interchangeable, and you could hook up to our CPAP mask and use it as a Bi-PAP mask. So there are a trillion different sizes and styles of masks. There is a wide variety, and everybody wants to sell one and make money, and everybody tweaks it slightly, and then it's a new design, yada yada. As a caution, you can use the hospital non-invasive mask. However, is it vented or non-vented? That is a really good question to ask RT or the nurse. Is your mask vented? Another question you should always ask is your flow additive? And so in general, if that elbow is clear, then it is vented. In general, if that elbow on the mask is a solid color, then it is not vented. Our masks are not vented because we don't want leaks, or we want the minimal leaks the most as possible. Looking at, it's not 100%, you're going to find exceptions to the rule always. I have had several of my last BiPAP calls that I've been able to leave the hospital mask on. And it also depends on where that vent is located, because a lot of the new masks, the vent is located a little bit further downstream. So you can actually take that off above stream and then connect, and now you have caused their vented mask to become a non-vented mask. And so really you just have to look at it. You have to ask, you have to figure it out. Is it vented or non-vented? Because in the transport world, we are going to need non-vented because we can't have that big of a leak. Looking at the hospital doesn't mind leaks. They don't mind having a vented mask because, there is their oxygen supply right there. Ours is this big. Actually, no, wait, it's about that big. And so we do greatly care about leaks because we don't have an unlimited oxygen supply. What's really good for leaks, you can grab one in the CC gray bag, or you can just ask the hospital for one. They make these nasal pads, which go on the bridge of the nose, making it more comfortable for the patient. Especially elderly, they get really, really bad sores from the pressure of the mask sitting on the bridge of their nose. And so we have now purchased these. We have them in the gray CC bags. They work really good for comfort. They also work excellent for when your patient has, say, an NG tube. Okay, the NG tube is running down their nose and out the side of the seal, thus creating a huge leak. And so you can take one of these, you can put it over the top of the NG tube on the seal mark of the mask, and then you can put the mask over the top of that. It works astoundingly well. I was on a call trying to get it sealed, and RT is like, oh, just wait a second, jumps up, runs out of the room, comes back in with one of these, and he's like, here, puts it over the top of the NG tube, it sealed it up immediately. Like, well, I wish you would have thought of this, 20 minutes ago when we were fiddling around with the mask. And then we could have sealed it up in 2 seconds and been on our way. So these are very wonderful things. Please use them. We'll have them. If you need more, let me know or let your supervisor know and we can get more. But they're very helpful. Looking at PSV Rise, PSV Cycle, and PSV T-Max, when you click on PSV, these 3 buttons on the bottom will pop up. And PSV Rise control selects the inspiratory rise time profile for pressure support, for PRVC, and for spontaneous breaths. The rise time profiles are numbered 1 through 9, where 1 is the fastest rise time and 9 is the slowest rise time. And starting with the fastest rise time, we can look at profile 1. We can see it's a faster rise. Whereas if we look at profile number 9, it is a much slower rise. And so for each increment, it is approximately 33% longer than the previous one. The rise time settings take effect on the next pressure support breath. If we look at the PSV cycle is set as a percentage. Ours the NV does 10 through 40% and defaults at 25. 25% is pretty much standard across the board. Normally you don't have to mess with PSV Rise nor PSV cycle time very much, but it can come in very useful. During PSV, the patient both triggers and cycles the breath. Let's say that again. During pressure support ventilation, the patient both causes the vent to deliver positive pressure into the patient's lungs, and then the patient again also causes the cycle to end itself. The algorithms used to cycle PSV breaths have traditionally been fixed at a certain percentage of peak inspiratory flow, meaning that when the patient's inspiratory flow decreases to a predetermined level, classically 25%, the breath cycle would move into exhalation. And we can see that here. And then the 10% versus the 40%. PSV T-Max, if you've ever been on a Bi-PAP call where the patient takes a breath and then it clicks, takes another breath immediately, that's because the patient wanted to be able to breathe for longer than the PSV T-Max. And so this is how many seconds that it's going to allow you to automatically breathe in before it's going to time out. And that could come in handy for when you have a very young patient, or if you want a very short amount of time, or if your patient is going to just want longer breaths and keeps on having this triggered, that could come in handy to know how to adjust that. As a side note, we have the Chemtron wall adapter, which what we do is we take our tubing, we screw it into the Chemtron wall adapter, we plug it into the wall of the hospital. Hospital outlets have either the Chemtron or the Omeda adapter. We have both. And what we have done, coming to a CC gray bag near you soon, is we're just going to connect these two. That way we can click into the wall and we can quick click into the Omeda connector from the tank, And then we can quick disconnect and quick connect into our tank when it's time to move the patient from the wall oxygen over to our portable tank. So these will be coming to the CC bags soon. This way you don't have to screw into the Chemtron, and then when it comes time, you have to unscrew it out of the Chemtron and then rescrew it back into the Omida and then connect it. And so this eliminates that downtime of having to very fastly screw out, screw back in. This way it's a quick connect and a quick connect. And some of the hospitals have the Chemtrons on the wall, some of them have the Omida. It just depends. I've seen them both and have used them both. And so this will be coming to our gray bags soon, so be watching out for that. So on that note, have a very happy non-invasive positive pressure ventilation, continuous positive airway pressure support ventilation patients.